Okay, we'll start the next topic, and I'll be talking about intraoperative hyphema and how you deal with corneal haze. Now, what I mean by corneal haze is not corneal ulcer with a huge scar in the center and those sort of things. That's better addressed by a cornea specialist. What we are dealing with is what cataract surgeons deal with, and that is the peripheral corneal degenerations and this sort of vague corneal stromal dystrophy. How do you tackle these things? You can see in the top right, that's how a normal cornea looks. And the center, you can see how this kind of just a disturbing sort of a peripheral haze. Now, these are, central view is there, but at the same time, you find that every step makes it a little bit tougher. So what are the small tips I can give you to, that we can all use to make this a little clearer? One is keep the eye totally wet. If you're going to do a peribulbar block for an MS ICS, then the ocular surface will become dry. So make sure the surface is wet. Your assistant should be on her toes and make sure the corneal surface is wet. Next, use trypan blue as much as possible. So without trypan blue, you can also get away. But then after you do your rhexis, the rhexis margin becomes a little bit difficult to visualize. So for that reason, if you use trypan blue, you'll have a clear, at least a margin where the rhexis is, and the rest of the procedure, especially in SICS, where you need to make a decent size rhexis before you try to pull that thing out of the bag. You need to have a rhexis size. So here, this is like what Dr. Leena was talking about, an intumescent cataract where you need a decent size rhexis, especially with SICS. You don't want it to go to the periphery. You've decompressed, and multiple nicks I have made here, but I'm able to do so because I'm able to see the rhexis margin. The second thing is every microscope has got the retro illumination. Now, it is a good idea. Normally, we use both the retro and the direct illumination, but look how clear it is when you use only the retro. So pure retro illumination when you use, we will be able to visualize the rhexis a lot better. So in this case, without the pure retro, you are not able to see where the rhexis is. Here, the rhexis is very clear, and the IOL can be dialed properly into the bag. Otherwise, you really, if it is a rigid IOL, it's okay if it is in the sulcus, but ideally you want all the lenses to be perfectly inside the bag. Here you may miss and keep it in the angle also, in the anterior angle. So retro illumination really helps in that case. Just another thing of retro, look how it is without the retro illumination. Looks like all the cortex has been aspirated there and looks like it is complete. But as soon as you sort of flush and then turn only the retro on, you can see the difference that it creates by purely turning off the main and putting on pure retro. You can see how much of cortex and other stuff and all is there inside the bag. And then you can go in, you can clearly visualize the rhexis margin, you can clearly go and remove all these things. So these are very simple things that we can do in all microscopes. And even if your microscope doesn't have a good retro, nowadays we have a separate attachment. One such is OmniGlow, which I think Aurolab is now dealing with. I don't have any financial interest, but that one is extremely good. You can connect it to any microscope, and so all of us have an opportunity to have very good retro illumination. So this is an NS5 case. But you can see here, even if it is NS5, very good retro, you can do the rhexis. Now, what other problems come with this peripheral corneal degeneration? This is one such case, everything is over, and so it's finished, and then you're just hydrating. The last step when you're hydrating, you can see those two bumps over there, and where the arrows are pointing, and when you're hydrating, have a look at what happens to that bump. It has gone and become a Descemet's detachment in that area. And so you must remember that these corneal degenerations, they are predisposed to Descemet's also. So always you should pay more respect, even when you're doing small steps like introducing instruments, exiting instruments, hydrating. You have to be very, very careful because you can easily end up with a Descemet's detachment. Even in the last step of the surgery, you can end up with a problem like this. So now that the Descemet's is covering the pupillary axis, you will have to correct that or rectify that. In this case, since it was a shallow Descemet's, I got away with just putting an air bubble into the AC, kept it tight for about 5 minutes, kept the eye nice and globe nice and tight with that air bubble, and that was sufficient enough to rectify this problem in this particular case. So in this case, again, the standard thing of using trypan blue, I have not done. So without trypan blue, what happens is you cannot see the rhexis margin, and just like what I said, rhexis margin was not clear. I had to make a slightly bigger margin, and that thing ran away to the periphery and caused some tear and extension to the posterior capsule. So I had to scoop the whole thing out into the angle out of the bag. And now I'm extending that 2.8 temporal incision and doing some back cuts on both sides and making it into a scleral tunnel. Now, normally this procedure is quite safe and it is quite in a controlled fashion. All you need to do is put one central suture over the 2.8 temporal incision and you're good to go. And this incision is stable and does not cause much problem. That is in a normal cornea. When you have a severe degeneration like this, you should be careful. The apposition of the corneal lips or the valves is not as good as a normal healthy cornea. Somehow these corneas behave a little differently. So this kind of stunts really doesn't work well when you have a corneal degeneration. So this particular patient, I just, internal lip, I'm just showing you here that it is a very nice healthy 2 millimeter internal lip. There's no problem with the incision at all. And normally speaking, I would just put one suture there at the main 2.8, that central area. But this particular case, I struggled a lot. So here it was actually an anterior capsular tear which had extended posteriorly. So a hydrophobic 3-piece IOL was placed into the sulcus. But the main problem was that after that, there was a nice amount of leak over there. So normally this one incision would do, and I'd make a suture there. But after one suture, 2 sutures, 3 sutures also, there was a significant amount of leak and it had a problem. Then it ended up in hypertoning. So in these corneal degenerations, I think the better step would be, if you're doing phaco and you have to convert for any reason, maybe a different site superiorly, you can put one suture and do superior MICS, and that would be more neat. Now quickly going into this intraoperative hyphema, which is a common thing that you see much more in MSICS as compared to phaco. It is coming from the scleral bed. So basically, the standard thing is keep the eyeball firm, and just doing that itself usually makes the blood clot, and then within 2 to 3 minutes you're fine, and you can just not do anything else. But if your corneoscleral tunnel is not well constructed, then and the corneal lip is not good, then it will leak and go into the eye. So corneal lip has to be very good. And even after that, in this case, you can see the corneoscleral lip there is no problem in the internal incision either, but there is significant amount of bleeding. So I knew that this was a major bleed. So I had to see what was going on. And retracting the conjunctiva, since I do a transconjunctival incision, retracting it, I was able to see what the problem was. There it is. It is a incision which has gone vertically backwards rather than parallel to the limbus. And that was what is causing that bleed over there. So somehow that has to be relieved, and the pressure inside the scleral pocket should be less than that of the outside, less than that of the eye. So once I make that nick over there on the side, you can see that the gushing of blood coming out to the external aspect, and now it is no longer going inside. So external lip, when you make it a very small incisions, external lip, this is one thing you'll tend to have more of bleeding into the eye, and unless the eye is very well formed, you can have this challenge. The other thing is, when you have hyphema, sometimes it tracks behind the IOL and onto the posterior capsule. You must wash out all that. You can see there was absolutely no glow, but now you can see after washing out, it becomes clear. So if you leave it like that also, it will get aspirated, but the next day the patient may have hand movements vision, and it will take a long time for that to clear. So it is very important, go in front and behind the IOL and all that, remove every trace of blood that is there before you close the case. Normally what we see is, when there is a beginner or premature entry or whatever, those incisions you have to take sutures and close it up. Otherwise hypotony will be there. Even if on the table it is okay, next day the patient will have hyphema, and inevitably you'll have to take it up the next day. So that is suturing and making sure the eye is nice and taut and firm is very important at the end of the procedure. Thank you.
This hyphema can be a bad problem in MSICS. There are 2-3 precautions. One is, as Dr. Ashish said beautifully, keep it tight. The other thing is, keep the tunnel long if you think that there's going to be hyphema, if you expect it. Number 3 is, once it starts bleeding, one tip is that don't wash the area which bleeds. Let it clot. And to make the globe tight, to introduce water into the anterior chamber, use a side port or another part of the tunnel. But the bleeding area you should not touch, because if you touch that area, it will bleed more. So these are a couple of tips.
Very nice presentation, Ashish. Good morning, friends. I just want to add one point, because some microscopes, they may not have retro. So in those cases, what I would suggest is just use an endo illuminator. If you have an endo illuminator, access to an endo illuminator, just put the endo illuminator there, then you will be able to see that. Just like a retro, you'll be able to see that. Even in presence of corneal haze, the endo illuminator, I use the endo illuminator or you can use a chandelier also. and if you have access to it. But endovillmetry, I'm sure everybody can get it. It's not a very big issue.